Hi, welcome to the August edition of Ask the Medical Director. I'm here with Jen Shea, and I am Dr. Kari Haley.
We've gotten some great questions from CME, and this is a format that we can ask the medical director. So recently, we've had a lot of shortages of D10, and there's a thinking process about what we're going to do if shortages become more prevalent.
Yeah, so we use D10 oftentimes in our hypoglycemic patients. So patients who often can present on a spectrum from a little goofy to completely obtunded. I think we've moved a lot towards using IVs and using that D10 and even those kind of slightly goofy patients because we know that it works right away, it's fast acting, and the patient gets better. With this shortage, I think we need to start thinking about alternatives, so thinking about oral challenges with glucose, so those patients who maybe are a little bit goofy, protecting their airway, handling their secretions, they may be able to get some oral glucose. It might take a little bit longer, but they will get better because, again, that is still sugar. Other options to think about are going back to glucagon, the IM medication. So again, that's going to take a little bit longer, 20 minutes, maybe more. But again, we know that does help and does make patients better. It's just that waiting period. I think we really need to reserve our D10 for those patients who are truly more obtunded, not protecting their airway, who have a significantly low sugar that we really want to get up right away rather than waiting for the glucagon. I think if it goes out completely, glucagon's still going to be a really good option. And if we just have no other options, that's going to probably end up what we end up needing to do.
There's been some discussion in critical case review in particular about calling a stay room when ketamine is used.
Yeah, so in our guidelines we use ketamine oftentimes for significant agitation. And I like to think about this as a patient who is really, really sick. They're acidemic, they have a lot of acid buildup, they are not able to keep themselves safe, or they are a danger to others and significantly, and they need that sedation from ketamine in order to maintain that, going back to a little bit more homeostasis, and recognizing that they're very, very sick is really the thought behind the stay room, meaning that they need a cardiac monitor, their airway needs to be monitored very closely, and when they get to the hospital, they should have a doc in the room, and they should be on a monitored bed because they are that sick, because that's really our indication for giving ketamine.
I have one more question from BLS CME. They were wondering about using CPAP and trauma. Some patients who've been involved in traumatic injuries feel like they can't breathe.
So when I think about that, again, what does CPAP do? It keeps the airways open, so it's really good to help with those patients who are retaining, like COPD or CHF patients who need to keep those alveoli open. In trauma, when people can't breathe, it's usually for a couple different reasons. So one can be that they have a pneumothorax, so air outside of the lung space, to a hemothorax, so blood in the lungs. They also could be profoundly hypovolemic. That can cause them to feel short of breath, or that they are just in so much pain that they're splinting, they're not taking good deep breaths, maybe they have a lot of rib fractures but no hemothorax or pneumothorax. When you think about all of those reasons, CPAP really doesn't make sense. So you don't really think about, I need to keep my airways open, my alveoli open because I have a pneumothorax. That might just make things worse, blowing air into us, and then if there's a pneumothorax, they could expand the pneumothorax. Similar to hemothorax, it's not really going to change the amount of blood that is sitting there. When people are hypovolemic, they feel very short of breath because they're not getting the same oxygen delivery capacity as they normally do. CPAP really it's not going to help them necessarily, and they may have other contraindications, facial trauma, the hemothorax, pneumothorax, and if they're in pain, it's also not going to help. So never a person that says never is a great answer, but I can't think of any true clear indications in trauma specifically that CPAP would be super helpful in.
As always, if you have any questions, send them in through the EMS education inbox. And again, thank you from Regions EMS.